medical, internal medicine or hematology, right? But nonetheless, it is something they have to know. Okay, the next is bleeding and clotting, right? It's even at this stage, talking about bleeding and clotting is not as simple as you may think. Yeah? Even at this stage, even with doctors yang dah graduate or graduate a few times, dah buat master, it's not easy talking about concept of to understand bleeding and clotting, right? So what more for undergraduate? Kita faham, you don't see the patient lagi lah. Kenapa banyak imagine, right? But as long as your basics are sound, your basics are sound, um, uh, it will help him, right? Because the bleeder and the clotter, okay, bleeding and clotting disorders is not confined to just one discipline. Okay, so if you are a surgeon, bleeders and clotters, identifying, understanding is very important for surgeons. Okay, pediatrics, ONG specialists. Okay, so everybody has to have that sound basics of what is bleeding, how to assess bleeding, understanding clotters, who clots, and what are the dangers of people who bleed and clot. Okay, and then in the end, it's all about trying to mitigate, mengurangkan risiko. You identify risk, you manage. Betul tak? Manage the risk before you see patient bleeding or clotting in front of you. Okay, so just keep that in mind. That is why you learn all this, to grasp this understanding, and hopefully it will be helpful for you when you see patients. Right, so hemostasis, I'm sure, is covered in first year and second year. So we will go through just a little bit to recap. Yeah? Yang dah tak dengar all these terms for about a year and a half. So recap. Go. Hello? Another? Okay, so another? Okay, so bleeding, hemostasis is actually a response to bleeding, alright? And the response will depend on the severity of the bleeding, okay? So if you bleed from a cut, paper cut, paling senang. Okay, you can bleed from a paper cut, or you bleed while you are cooking, knife injury. Okay, suddenly the slice your finger or your hand. It's fading. Macam mana pun dia macam fading. Microphone. Okay, so that is bleeding. If you have a stab injury or gunshot wound, patients, do people bleed? Yes, they do. But to a more severe extent. So the response to bleeding is the same. The hemostasis will kick in, but at a different degree. Okay, so hemostasis is physiological. Alright, in fact, it's happening now. Okay, you get injuries to small blood vessels every single minute, every single second of every day, while you are standing. While I'm standing. Okay, you injure blood vessels, small blood vessels, but no harm, no foul. Okay, hemostasis kicks in, right, and is able to correct that before it becomes something worse. So it's rapid and it's meant to be localized to the site of vascular injury. Okay, so I want you to compartmentalize this from inflammation. Does inflammation involve bleeding? No. Okay, no, it's just that, okay, in when we talk about injury, if there is substantial tissue injury, you would damage blood vessels as well. Okay. But to compartmentalize, to understand the physiology or the pathophysiology, it is separate. Okay. Inflammation is inflammation. Okay, hemostasis or response to bleeding is different. Okay, but they can happen at the same time. Okay, kalau tak dengar boleh datang depan because I don't know, we don't know what else to do with the microphone. Okay, so the idea is to always keep blood moving. Okay, as you sleep, as you walk, talk, eat. Okay, blood remains in motion. Mesti bergerak. Tak boleh tak bergerak. So that's why this response is important. And there are two pathological states to hemostasis. Number one is thrombosis, which you have had a lecture on, some exposure on thrombosis. Okay, and the other is hemorrhage. Okay, hemorrhage. Does the word hemorrhage appear anywhere in acute or chronic inflammation? Ada ke tak ada? Ada ke tak ada? Good. Tak tengok dah lecture ni. Belum exam tak tengok. Tak ada. Okay, tak ada. So that's why it's big bewildering every time when we give you an example, okay, of a tissue, okay, with red cells, okay, and it's actually a picture depicting the effects of inflammation. Your go-to word is always hemorrhage. You know it's already, it's inflammation, but you keep describing it as hemorrhage when you see red blood cells. Why do red blood cells become prominent in inflammation? We give you tissue. Why? Why? Anyone can answer? Yes. Anyone can answer?
Leaky
Why?
vessel.
Yes.
Leaky blood vessel.
Sorry?
Leaky blood vessel. Increase permeability. So
In leaky blood vessel, your lecturer ajar blood will go through this leaky blood vessel. Is it? Really? Tunjuk dekat I kat mana? I ke yang bagi lecture tu? Ya, I yang bagi lecture tu. I tahu. Tengok. Okay, but don't worry, I'm sure you're not the only one who's thought about it. Orang lain pun fikir tadi asal. What is the vascular change? It's dilatation. Okay, when there's dilatation, darah banyak sikit. Banyak. That's why it becomes prominent. But the blood is inside the blood vessel. Okay. When you talk about hemorrhage, where is the blood?
outside.
Outside the blood vessel lah. Okay. You have to loosen up and think logic. Don't always give answers that you think that's what we want to hear. Okay, use your logical thinking. Okay? Logical thinking. Okay, so hemorrhage, the blood is outside the blood vessel. Alright? So when it's outside the blood vessel, if it's a gunshot wound or stab wound, do you see blood gushing out? Yes. Okay, you can see blood gushing out. Okay, but if there was tak ada. There's no penetrating injury causing tissue damage. Okay, but the patient is bleeding internally. spleen rupture, liver rupture, for whatever reason. Do they bleed? Yes, they do. Okay, so blood is escaping from the blood vessel. Alright, so that is why the initial response is vasoconstriction. Ni nanti profesional nanti semua terbalik-balik dengan inflammation. Right? That's why it's important to compartmentalize at this stage. Okay? But as you go along in your studies as a doctor, you will understand that all of this is very dynamic. Betul tak? Dia bukan kata, okay, ambil nombor inflammation dulu. Dan yang kedua, baru berlaku. No. Okay? Right, so this is just a way for you to understand and compartmentalize. Okay, so the first is vasoconstriction. Okay, dia tak adalah constrict sampai apa? Sampai ke sini. Okay, so it just has to apa? Kalau pipe bocor, what you need to do?
Tutup
Tutup sikit. Kan, apa tutup sekejap. Okay, until you find the cause of the, right? So, right, so that is the initial, okay, the initial response. Okay, so this happens, okay, in order for primary hemostasis to occur. Okay, so go back, tengok balik lecture note apa ke, what is primary hemostasis. Okay, so primary hemostasis, you can see here, is all about forming a primary hemostatic plug. Okay, so what forms this primary hemostatic plug? Is mainly apa? Platelets. Okay, so you can see this diagram, example of injury. Okay, so there's injury to the blood vessels. You can see that there's loss of some endothelial cells there for whatever reason, but there's injury there. Okay, so what fills this gap first are your platelets. Platelet duduk kat mana, adik-adik? Mana? Ha? Dalam blood vessel, dia jalan dengan siapa? Dia jalan dalam darah, dalam apa? Plasma. Yes, very good. Dia jalan dalam plasma. So macam mana dia nak tahu, dia nak singgah, how does it know to come and stop at this area of injury? How does it know? How does it know? There has to be signals, receptors, ligands that are expressing on that site of injury to actually call it. Okay, because call, for undergraduate whatever you want to say, call or pull or attract. Okay, but to actually attract the platelets to the site of injury. Okay, certain receptors. Okay, so that is your first. That is the first objective of hemostasis. Right, but is it enough? No. You have to go to the second part of hemostasis. Secondary hemostasis, which is more concrete. Okay, so platelets are flimsy. Okay, they provide just an initial plaster. Okay, a bit of plaster dekat situ, but in the end you need to cement that that clot. Okay, so that is where your secondary hemostasis occurs. Okay, so secondary hemostasis will usually involve your coagulation factors. So datanglah that's where your coagulation waterfall cascade happens on the side of the platelets. Nampak tak? Ingat tak? Ingat balik. Okay, that is where the site of coagulation occurs with your coagulation factors, right? So in the end, what we want is fibrin polymerization. I used to put a lot of words here, okay, but sebenarnya memang tak boleh ingat. Okay, so I just retain the main idea of what is secondary and primary hemostasis. So fibrin polymerization. go back tengok balik. Okay, estimate sama-sama what is fibrin polymerization. What does that entail? Right, and then afterwards, after you have formed this magnificent fibrin, okay, to help with the plugging of the site of injury, of vascular injury. So dah tak bocor dah. Okay, dah tak bocor. So countermeasures need to come in. Okay, so these countermeasures usually memang apa? You all buat tak pandang je. Ingat ABC. D tiba-tiba terlupa. Okay, but D is important. What? Why? Because it needs to limit this hemostatic process. Okay, so it cannot be growing until it occludes the blood vessel. Betul tak? It needs to stay on the surface side. Okay, so that's where countermeasures come in, and these countermeasures is called fibrinolysis. So fibrinolysis is is the normal part of the hemostasis process. Okay, so these four go back and try to read up. Okay, so you can. This is already basic, so just go back and reiterate your coagulation cascade. You have your intrinsic, extrinsic. What do you mean by extrinsic? What do you mean by extrinsic? Okay, which one is the common pathway? Common pathway start dari mana? X. Start dari mana? Okay. So what factors are involved in extrinsic and intrinsic? That has always been important because only then you understand your blood test. Okay. Alright. Okay, so this is fibrinolysis. Okay, what I mentioned before. Okay, so it's to prevent excessive fibrin deposition. So it's a natural defense against vascular occlusion and helps to keep the clot on the surface. Right? Until apa? Until healing comes along lah. If healing needs to come along. Kan? Dah belajar kan process of healing?
Yeah.
Yeah? Not your healing. Healing in the scientific sense. Okay? Then healing will come. Okay? Okay, so this is a summary. And there are so many. Tak cakap, tak nampak. I don't know sendiri. Okay. Alright, so there are many depictions of how to view hemostasis. Right, so but I kind of like this way you are free to scour the internet and look for other ways to visualize the entire process. Right, so you don't see it as a too large of a subject to comprehend. Okay, it's actually encompassed in this small diagram. Okay, so vasoconstriction, primary hemostasis, secondary hemostasis, and fibrinolysis. Just what we are talking about just now, and it is within this. Okay, it is within this categorization where we will go into diseases, disorders. Okay, that you should know. Reward tahun depan ni nak tahu. Kan, you are already in training to diagnose. Right? It's not that after 6 years baru belajar macam mana nak diagnose. No, you are doing it on the job. When you go to year 4. Okay? So it's not it's exciting, but also you need knowledge. Okay, so we are throwing you all these diseases like Dr. Alina mentioned, kan? Cervical lymphadenopathy. Which one should I know? If patients come with enlarged lymph nodes for 2 months, 3 months, 6 months, increasing in see, kan? Already a junior doctor in the making. He can actually mention lymphoma. Okay, but medical students are required to give Differential diagnosis. Do not pin your hopes on just one. So there must be a systematic way of viewing, of approaching the case. And then it could be infection, inflammation, number one. Number two, it could be soft tissue enlargement, benign ke malignant. Kan? Baru dah banyak benda nak cakap dengan clinician. Okay, then you will know you are PBLing always in the ward. Kan? PBL selalu. Tapi kita kita break down the PBL session this year into two lah. Okay, but that is what you are meant to do. PBL on the job. Okay, so let's go into each category and learn a few diseases which comprise each category. Okay, so before that, investigating bleeding has never been easy. Never been easy. It gets easier if there is a resident hematologist in your hospital. But not all hospitals will have that luxury to have a hematologist on call or on the road in that hospital. Okay, so you are expected as the general doctor in your ward to actually, try to help and investigate a bleeding cause. Okay, so the problem with investigating bleeding is that there are so many facets. Betul tak? How do you investigate for defective vessel constriction? Contohnya, how do you investigate if there's a problem in primary hemostasis? How do you investigate if there's a problem in secondary hemostasis? How do you investigate if there's a problem in fibrinolysis? Okay, right. So I put up this first because it's a bit more general. Okay, and I put habis masa, I tak sempat tulis ini, I think it's quite important. Okay, so the usual screening, okay, is number one, a full blood count. So in the full blood count, you will have the platelet count. So agak-agak platelet count ni penting untuk apa? Vasoconstriction, primary, secondary, or fibrinolysis.
Primary.
Kan? Most of the time would be kita nak tengok dah your primary hemostasis. Is it a direct effect because of low platelet count? Okay, paling senang. Okay, so you investigate one commonly. Okay, kalau refer kepada hematologist pun kena ada this background information. At least you have done your due diligence. Okay, right. And then screening test for blood coagulation. So you have your prothrombin test, your activated partial thrombin time. Thrombin time. You have thrombin time and fibrinogen quantification. So agak-agak you all, this one untuk apa? To assess apa? Integrity of apa? Secondary hemostasis. Maybe primary hemostasis okay. Okay, but dia tak boleh nak maintain. Betul tak? Sebab it's meant to be apa? Very it's not the solution. You must go into polymerization. Make the clot concrete at the site of injury. Betul tak? So if you have any problems in in your coagulation cascade, it may reflect in your PT, APTT, TT, and fibrinogen level. Okay. So here you are not directly assessing the factors involved. Okay, rather the end effect. Okay, so PT would examine or would interrogate your extrinsic and common partial. Macam tak pernah tak?
Nah.
I tak tahu macam mana your second year ajar. Pernah dengar lah PT, APTT buat tak?
Buat.
Cucuk darah sendiri ke? Untuk buat test PT, APTT.
Kawan.
Kan? Okay. So APTT would interrogate your intrinsic and common. TT is basically to look at fibrinogen. Okay, fibrinogen. And fibrinogen quantification is direct effect of fibrinogen. Okay, alright. So it screens which factors in the cascade for you to focus on, because you cannot be thinking I nak check quantity of coagulation factor 1 sampai berapa? Ada berapa? Factor coagulation?
12.
Ah?
12.
Berapa?
12.
Berapa? Ya Rabbi.
12. 12.
Berapa?
12.
Siapa nak kat Starbucks?
12.
Tak ingat. Coagulation factor sampai berapa?
12.
Last tu berapa?
Jerit dah 12.
I tak tipu. I ada kat Starbucks RM30 already inside. Petang ni I bagi. Siapa?
12.
13. Yes. Factor 13. Ya. Nama apa? Musfira tunjuk kat saya. Hantu Starbucks lah. Okay. Right, so you
13.
cannot be going into
12.
everything. That's why you need to focus your research. Okay, focus what you want to do. So that's why we screen dulu. Kan? Kalau PT dia normal, you nak pergi buat factor 7 dan buat apa? Mangga orang. Ada. Nanti dia akan tanya apa? Siapa ajar ni? Okay, ya biasa. Sini je, record sini je. Don't take it too hard. Semua orang dah pernah dengar. Alright? Awak tu? Dengar? Awak tidur kan? Boleh terlepas. Okay. Alright. And then we have bleeding time. Buat tak bleeding time masa undergraduate? Telinga siapa yang kena cucuk buat bleeding time? Tak ada. Semua tak berani buat. Tak berani cucuk. Belajar teori sahaja. Okay, cucuk kat mana? Cucuk kat mana? Yes, kan? Cucuk kat tepi telinga. Tak buat Tak buat. Okay. So bleeding time is quite an ancient test, non-specific, but some hematologists or hematopathologists still like to have that kind of a whole picture. BP, semua lah is good one. Okay? So it does have its uses, I wouldn't say it doesn't, but it's coming out of fashion. Okay? Bayangkan budak-budak nangis-nangis you nak examine dia, nak cucuk. Okay? It becomes very awkward in front of the parents. Kan? Okay? Right, and then you have your specific type assays. Okay, so coagulation factor, and then you have platelet function. Okay, test for fibrinolysis. Okay, and overall cord integrity. Ini semua zaman sekarang lah, this is 21st century type of testing lah. Masa I belajar dulu tak ada semua. Alright. Okay, so now you can investigate. Betul tak? You know where these tests belong to and why you are doing that. Okay, belajar tahu kat mana PT, FPT, duduk kat mana, so on and so forth. Alright? Okay, so now we are going, baru nak masuk di sini. Tapi kita start lambat tadi kan, so kita habis lambat. Okay, so let's go into all those disorders. Alright? And if you can see here, okay, I have divided them that all of these disorders have a inherited and acquired component. Okay, for platelet disorders, it can be quantitative or qualitative. Quanti meaning apa? The direct effect of the number. Yeah. Okay. So, but that also has a acquired and inherited component. Same with qualitative, right? Okay. Right, so let's look at some bleeding disorders. All disorders that cause you to bleed more than usual. Okay, so vascular defects or disorders can be inherited or acquired, but the more common would be acquired. Nampak tak? Besar kan? Besar kan? Jangan tak okey. Okay. So asal dia besarkan font. Okay, so the acquired is more common, right? So this would include senile pura okay, pura because of apa? Acquired urine infection. Pernah dapat dengue? Pernah dapat dengue? Pernah dapat any viral fever actually it can cause you to have a rash or kind of like purpura kita panggil okay, purpuric rash. Okay, so those are actually very small apa pinpoint bleeding, superficial bleeding. Okay, so we have inox purpura, which is inflammation of blood vessels in children, which is immune mediated. Immune mediated. So the blood vessel become a bit a bit more ini blood vessel blood vessel becomes a bit more the endothelial cells tu dia open and it's large enough to let blood escape. Okay, right, and then you have vitamin C deficiency, okay, and deposition of enzymes. All this can be a reason why you bleed more. Okay? And this type of bleeding, okay, before we go into that, so the inherited causes ada banyak sebenarnya, but I just put a few only. A few only. So the main mechanism is that probably these people are born with an abnormal cell lining, vascular lining, cellular lining of blood vessel formation. There's problem in the collagen. Okay, so collagen anywhere where there's collagen, there's a problem. So you have a lot of collagen in blood vessels, and there may be loss of perivascular support tissue. Okay, so some of the diseases, contohnya hereditary hemorrhagic telangiectasia, rare. All of these are rare. Okay, but if we need you to give some example, dalam buku ada banyak. Okay, so if you can see, okay, the bleeding is apa? Okay, it's vascular, it's quite superficial, right? It's quite superficial, right? So unless it's a bleeding disorder that yes, it causes vascular decirculation and whatnot, and whether it involves it's more severe that it can cause bleeding internally. So you would have to look into those different conditions and see whether this is something that happens. But for the most part, you can see the vascular defect already superficially because you have so many blood vessels on the surface already. Okay? So it doesn't mean that it doesn't happen anywhere else, right? So this is the type of pattern. So it's all about identifying pattern juga. Okay, certain conditions will have a certain pattern to the, and if you can imagine the depiction of the different components of hemostasis. I did not put in a lab test for investigating about blood vessel integrity. Ada tak tadi? Tak ada. There's no good test. Okay, there is no good test to investigate for vascular defect. So you see by eye, okay, to identify. Right. So the longer list is in platelet disorders. Okay, so platelet have quantitative and qualitative. Okay, so the quantitative deficiency is known as thrombocytopenia. Okay, and there are many reasons for this. Okay, but the main reasons kita bagi apa? Themes sikit lah, tema. Okay, it's either you cannot produce any platelets. Platelets are produced where? Where? Bone marrow. Yes, produced in the bone marrow. Okay, so either your tulang is not producing, okay, or there is increase of consumption. Okay, maksudnya it has already gone into the blood and it is being consumed for whatever reason. Digunakan tulang ni. Okay, so these are some of the needs. And then there's abnormal distribution of platelets. Platelets being sequestered in any organ. Okay, and this usually happens with splenomegaly. Splenomegaly. Right? So when there's thrombocytopenia, usually the first thing you would see is whether the patient has splenomegaly. Okay, because patient is in front of you before you get any other blood tests. Okay, and it could be dilutional process. You're pumping in too much fluids and spleen dilution. Okay, this can happen in emergency situation. Okay. So for qualitative disorder, okay, qualitative, meaning the quality of your platelet, how it functions, or the degree of its dysfunction. Okay, so in this case, platelet count, you see, oh, platelet count is 170. Is it enough? Cukup tak? Is it within normal range? Not sure. So more than 150 will be normal. Okay. But the patient is still showing signs of bleeding. Adalah bruise here and there. Okay. So it could be a functional issue. Okay, it's not functional. Banyak macam mana pun you have a defective product, it's not going to work properly. Okay, so the most common would be acquired. Okay, and this is usually because of drugs. Okay, drugs. Different types of medication, aspirin, you are familiar with?
Yes.
Clopidogrel, dah belajar dah? Antiplatelet, belum lagi?
Dah.
Dalam
Dah.
CPS punya ubat-ubat tak belajar lagi?
Dah.
Kenapa you geleng balik? Okay, tengok balik. Betul. Okay.
Baru je.
It could be secondary to other diseases. To other diseases, multiple myeloma, myeloproliferative, myelodysplasia. Okay, patients with uremia. What patients will have uremia? A build-up of urea in their blood. Patients with apa? With apa? Why do you have urea build-up? Urea you supposed to excrete. Siapa yang tak boleh excrete? Patient with kidney failure. So kan, fikir logik dah masuk renal belum? Belum. Tapi apa? You can think logically. Okay lah. So patients with some renal impairment, maybe retaining their urea, and to a certain degree it may cause platelet dysfunction. Okay, so you can go through this. Okay, so one of those diseases that you would encounter more often than not is idiopathic thrombocytopenic purpura. Okay, so this falls under the category of platelet destruction. Okay, some will say consumption / destruction. Okay, right. So what happens is that why is the platelet being destroyed? So what happens is, okay, so there are platelet autoantibodies. Okay, so these antibodies, they identify the platelets, and once antibody has latched on to its antigen, where does it bring it to? Dia bawa ke mana? Dia kumun macam ni, lepas tu dia nak bawa ke mana? Dia bawa ke spleen. Okay, some may bawa ke liver depending, okay, but mostly to the spleen. Apa berlaku dekat spleen?
Dia akan degrade, destruction.
For removal. For removal. Okay, the reason why is because it has a multitude of SC receptors jutting out. So this happens conceptually in any disease, in any disorder, where you have antibody latch onto the antigen. In this case, it's platelet. It may happen to red cells also. Okay, so it brings them to the spleen. Okay, FC receptors like a conveyor belt is apa mengelilingi lah the sinusoids in the spleen. If it recognizes the FC receptor, okay, kita tarik keluar dulu. Out from circulation. Tinggal dalam spleen, dia proses-proses dulu, oh tak lulus. QC tak lulus. Effective product. Okay, so it becomes destroyed. Okay. So ada okay. Right, so it's premature removal. The normal lifespan would be okay. So what do you see? Clinically, these patients are usually young women. Okay, and this is usually what we call a diagnosis of exclusion. Apa maksud dia? Diagnosis of exclusion. You have to exclude other things first. Before you put the finger on ITP. Okay. What other causes of thrombocytopenia? Okay. Tak jumpa. Okay. Other things are so unlikely. Okay. Then this may well be ITP. Okay. So it's usually idiopathic, but we may see it with patients with SLE, HIV infection, patients with CLL apa?
Chronic lymphoid
Lymphocytic leukemia, okay, or any types of lymphoma. Why? Because there's immune dysregulation in these diseases. Okay. Boleh make that connection. Why it can happen. Right? Okay. So you can study a bit about IT. Right. So abnormal distribution contohnya is when you have abnormal sequestration of platelets, and this happens usually if you have a very large spleen. Okay. So 90% of platelet is sequestered in the spleen, where normally it should just be around 30%. Okay, so this would also contribute to thrombocytopenia. Okay, so how do you diagnose? Okay, so usually you already see a full blood count with a platelet count of very low, usually 10 to 50. But other parameters are all normal. Isolated thrombocytopenia, or if there were abnormal counts, you could be explained. Okay, so in this instance, it's important to have a morphological examination, a peripheral blood smear, showing thrombocytopenia, true thrombocytopenia, and the platelets are usually large, sikit, tapi they can be large. So bone marrow I letak seberapa plus minus. Usually we want to avoid doing a bone marrow exam. But currently it's getting more and more common to especially in adults, to perform a bone marrow aspirate to exclude all other causes. Okay, you go to the source, you go to the kilang, tengok sendiri kan produk efektif ataupun examine the environment of the kilang. Okay, so it's getting more and more commonplace to do bone marrow aspiration. Okay. And then you should do also, if you can, if it's provided, an anti-GP2B3B or GP1B antibody test. So the cause is immune. There's an antibody or an auto-antibody that is responsible for removing your platelets. Okay, so you need to demonstrate. You need to demonstrate the antibody, but it's not routinely done. It's a specialized test. You need to phone up special people to do this test. Okay. Right. Okay. So that was destruction. Some people say consumption, some people say destruction, but usually you will read it will be as destruction. Okay, so for thrombocytopenia because of consumption. Consumption apa? Use. Yes, you are using too much. As a consumer, you are using too much. You are using too much. So there is, in this case, a derangement of coagulation due to excessive consumption of platelets. So this may present with thrombosis and or with or without bleeding. And this is typically what we see on the peripheral blood as microangiopathic hemolytic anemia picture. Okay, pernah dengar MAHA? Have you been exposed to MAHA? Yes. In what lecture?
Anemia.
Okay, so microangiopathic hemolytic anemia is a morphology diagnosis. Okay, is a morphology diagnosis. Okay, so in the literature currently, the clinical syndrome is rebranded TMA. TMA. T microangiopathy. Okay, I'll look it up. Okay, TMA. That is the clinical syndrome. Okay, so some disorders that may show a MAHA picture, microangiopathic hemolytic anemia picture, okay, are these. Okay, heparin-induced thrombocytopenia, thrombotic microangiopathy such as THUS, monoclonal, and the IC. We will look into the IC a bit more in this lecture. Okay. Right, so this is MAHA, right? Red cells with straight edges. Okay, red cells should never have straight edges, but these have straight edges.
Straight
Okay,
edges.
and apart from that, there is no pigment. Okay. However, MAHA you can have with and without thrombocytopenia, but for undergraduate, for the purpose of kind of like imprinting on a common presentation, on a common pattern, MAHA is usually associated with open. Right, so next going into nak tanya apa? Belakang? Ha? Oh, bukan tanya. Oh. Angkat dua-dua tangan, ingat tak minta tolong. Okay, so inherited platelet function disorders. Platelet function. Okay, so the platelet, as you know, it travels in the plasma. Okay, and if it cannot bind, it is useless. Betul tak? Dia lari dalam tapi dia tak boleh bind. Okay, it cannot perform primary hemostasis. Okay, so some of those include Glanzmann thrombus, tinea, Bernard-Saudier syndrome, and storage pool disease. Okay, so this is a very simplistic view of these inherited platelet function disorders. Enough for you to know that it involves deficiency of certain receptors for it to grasp on. Okay, so Bernard-Saudier is a deficiency of GP1B. Glanzmann is deficiency of GP2B.
Glanzmann. Dia
B3A, tak silap. B3A. Okay, 2B3A. And there's also storage pool disease. Okay, the platelets have granules but fail to use the
inherited
to exert its function.
disorder.
Okay. Next, so we've already seen vascular, we've already seen your platelet disorders. Now we are going into coagulation disorders. Tadi doktor lagi tak? Tak kan? Baru satu sistem. Okay, satu sistem with many facets, so there's many diseases. Okay. Alright, so for coagulation disorders, again, your acquired is more common. Okay, acquired. So look into deficiency of vitamin K dependent factors. Apa ya vitamin K dependent factors? Yes, anyone? Tak sure? Okay, nanti pergi tengok lah di darat ni. Tapi, what? Okay, so look into what are vitamin K dependent factors. Could there be inhibition of coagulation because of specific antibodies? Okay, so you can see this in diseases such as lupus, rheumatoid arthritis. These are all like immune dysregulation types. Grow off inhibitory antibodies, okay, and also other causes, drugs and whatnot. Okay, and then you have the inherited form. Okay, so these inherited forms are quite important for you to remember. Even though they are inherited, kita kata dia rare juga, but it is important for you to remember. Okay, because we see them more compared to qualitative inherited disorders or platelet any inherited disorders of the platelet impact or vascular inherited effect. Inherited causes of coagulation disorders are more common. Okay, so that is hemophilia A, B, and von Willebrand disease. But of course, there are more. Just for the sake of this lecture, yang ini yang penting lah. Okay, so what is the relationship between von Willebrand factor, factor 8, and platelet? Ini penting. Why? Because you have factor 8 here. Okay, you have von Willebrand here. Okay, and then platelet also comes into the picture. Okay, so this happens. Okay, so factor 8. Sorry, kat sini dulu lah. So your von Willebrand factor actually works where?
Dekat
Primary hemostasis, secondary hemostasis, fibrinolysis,
Sec-
or at the vessel?
secondary.
Yang mana? Siapa berani jawab? At the vessel. At the vessel stage. Primary. Alright? On the vessel. Dia macam mana? Dia in between vessel and platelet. Why? Okay, because it is expressed here. See? Subendothelial. So it's expressed when there's injury. Okay, but it's important because it expresses the receptor to attract platelets, to help attract platelets. That's why it's kind of like in between your vascular and your primary hemostasis. Okay, right. And what is the relationship between factor 8 and von Willebrand factor? So von Willebrand so they travel together. Okay, your factor 8 and your von Willebrand factor. They complex together, and I'm not sure which one protects it. Is it von? I think it's von Willebrand protects your factor. And it protects the factor. Okay. Right. So that is the relationship between von Willebrand factor, factor 8, and okay. Alright. So looking at hemophilia. Okay, looking at hemophilia. So this is hemophilia. So hemophilia is it's an X-linked disorder. Okay, and in this X-linked disorder, it means that if you have one X chromosome, and that X chromosome carries the mutation, okay, then you are affected. For women, you have two X chromosomes. If you have only one, you are a carrier. Okay, so you need both to become affected in women. So that's why it is very rare for women to have hemophilia. Okay, I wouldn't say tak ada, but it's very rare. But it's common to become a carrier. Okay, so two scenarios would involve either the father, okay, as a man, as a male, has the affected X chromosome, so he's already a hemophiliac, marries a normal, or a mother who is a carrier marries a normal male. Okay, and the underlying consequences of that marriage. Okay, so when you do when you discuss inheritance or risk of having children with hemophilia, with hemophilia, so this will be for every pregnancy. For every pregnancy, each time you get pregnant, in this case, each time you get pregnant with a male, okay, you are pregnant with a male child, he will be normal because obviously his X chromosome would come from the normal mother. However, all your daughters will become carriers because the daughter would definitely get one of the X chromosome from the father. Okay, faham? In this instance, okay, the mother is a carrier and the father is a normal male. For every pregnancy, which is a male, okay, you have about 50% chance of getting a child who is affected, a male child who is affected. Okay, but your overall risk, if you do not know the gender, tak ada gender reveal, okay, there's no gender. It is about 25% of every pregnancy. Okay, and same goes for your daughters. Okay, if you are pregnant with a female child, 50% chance that the child will be a carrier. Okay, right. Okay, so this is very simplistic view of hemophilia. Okay, of hemophilia. Okay, so next. Fine. So next is von Willebrand. Okay, von Willebrand. So von Willebrand disease. So now you know where von Willebrand factor functions in between. So directly on the blood vessel. Okay. So the problem with von Willebrand disease is that it has a few levels of severity. Mild, moderate, and severe type 1, type 2, you have a multitude of type 2 and type 3. Type 1 is mild, type 2 is usually functional or dysfunctional. Dysfunctional, we have a factor with or without low platelet, with or without factor A deficiency. Very complex, okay? So very simple, von Willebrand for one Willebrand explanation for you. So the commonest variant is type 1 and is characterized by reduced quantity of circulating von Willebrand factor. Okay, it is autosomal dominant. Rarely the mutation is autosomal recessive. Okay, alright. So for a one Willebrand factor, okay, so you know it works between your kind of like your vessel and also primary hemostasis. Okay, so if you did a APTT test, would it be affected? Would it be affected? Yes or no? Yes or no? Yes. Huh? Okay, kat sini celah mana your PT APTT? Any mention about coagulation cascade? No. Okay. So in the more common presentation, patient come with bleeding. Now, nanti orang nanti ada juga. Tapi the bleeding itu variable. Okay, mild, moderate, severe. Okay. But your PP and PTT is normal. Platelet can be normal in bone really right? Most of the time normal, unless you are a type 2, which is a kind of like a functional type. Okay, but most of the time is normal. Okay, so platelet count normal. So you can have this is the type where you get normal result and yet the presentation of the patient have a tendency to bleed. Pergi jumpa doktor gigi darah. Okay, untuk yang perempuan, setiap kali you have your period, pakai sampai apa? Pakai sampai apa? 4-5 pad satu hari. Okay, fully soap and they think it's normal. Because it happened to me, it happened to my sister. Check HB 10-9. Okay, 10-9 hemoglobin normal ke tak normal? Tak normal. It's anemia already. Okay, so that could be the trigger you to investigate for von Willebrand. Yeah? So the bleeding type would be dependent on what severity it is, but most common it is spontaneous bleeding from mucous membrane. That's why abatis also bleeding from tooth extraction, tooth manipulation, whatever lah, oral manipulation, or periods and whatnot, because it's menyebabkan mucus. Right. So so this is hemophilia. Okay, so if you can see, what is this? Bleeding into joints. Okay, what do you call this? Hematosis. Bleeding into joints. Very, very painful. Very, very painful. Okay, and this is the effect of repeated injury or bleeding into the knee. Okay, so this is neither superficial nor membranous. Okay, this is deep-seated bleeding. Okay, very different from your von Willebrand or your platelet or your clear cut vascular disorder. Right. Okay, so a typical diagnosis for hemophilia. What is important to note is that there will be prolonged APTT. Why? Factor 8 is involved in which pathway? Extrinsic or intrinsic? Intrinsic. My God. What is involved in extrinsic? Factor 7. Only factor 7. The rest all masuk plus ni. Hey. You must keep your life simple. You got so many things to learn. Okay? PT, PTT, PT7. PT7. PT is apa? Exclusive 7. Okay? The rest go in intrinsic and common. Okay, so you would have a prolonged PTT. Okay, and you would require, and that would trigger you to check the common factors under intrinsic. Okay, that's what we mean by screening and then you focus. Right, so factor 8 will confirm deficiencies, or factor 8 essays will confirm the diagnosis. Okay, last. Yeah, I never go beyond 30 slides, but it's very hard for reading and clotting to not go beyond 30 slides. Okay, DIC, complicated. Yes, very complicated. Okay, so this is also called consumption coagulopathy. Okay, dia consume sampai dia jadi hati. Sampai dia jadi disorder. Sampai dia jadi takut. Okay, so consume sampai begitu sekali. Right, so it is characterized by activation of your coagulation sequence leading to formation of thrombi throughout the microcirculation. Right, so all the blood vessels which you can see becomes thrombosed in DIC. Okay, so this is caused by consumption of platelets, coagulation factors, and activation of fibrinolysis. Okay, so we will see here. Alright, so the cause comes in first. Okay, there are different causes of DIC. Okay, whatever that triggers this release of tissue factor. Okay, and release of tissue factor is normal. It happens in normal hemostasis, but here it happens at a very large scale. So you can imagine that this happens quite systemic. Okay, systemic. Okay, so it could be massive tissue destruction for whatever cause, burns, very extensive accident, sepsis, very easily understood. And if you have any form of prolonged or widespread endothelial injury. Okay, so there's release of tissue factor. Okay, so tissue factor, tengok balik dia duduk dekat mana. The main use of tissue factor, intrinsic or extrinsic. Okay, so it doesn't happen in primary. I already dah bagi clue. It happens for secondary hemostasis. But nanti tengok balik. Is it intrinsic or extrinsic? Okay, so widespread, and this causes widespread microvascular thrombosis. Meaning apa? The whole of coagulation process, the normal process, is not localized anymore. Nampak tak keyword dia? It's not localized anymore. Normal, it should be localized. In DIC, it is no longer localized. You have widespread thrombosis. The clot formation tu terlalu banyak dan tidak okay? So you have widespread thrombosis. Okay? So when you have thrombosis, you occlude the blood vessel. Betul tak? So when you occlude the blood vessel, what happens to the tissue that is supplied by that blood vessel? The ischemic process begins. Okay? And in between that, because this vascular occlusion is not normal and it's widespread, small blood vessels, that is where your microangiopathic hemolytic anemia comes into play. Faham tak? So you have all these thrombosis. Your blood vessel is apa? Smooth. Betul tak? Smooth. Theta F1 cannot have debris on the road, right? Sama here. But here when you have thrombosis, can you imagine? Okay, got things jutting out. So blood tu nak lalu macam mana? Blood is like that, axial. Kalau dia ada all that, if there's debris on an F1 circuit, what happens?
Accident.
Dia langgar saja kan? There's no time to stop, no time to break, right? Kalau dia break, dia terkeluar. So usually apa? Langgar je, lempuk sahaja. Sama macam your red blood cells, dia apa? There's nowhere to go. Kan? Dia tak boleh nak ponah, dia straight sahaja. So dia rempuk sahaja. All those lumps and bumps in the middle of the blood vessel end up with apa? Jadi itu red cell lah. Red cell tu yang jadi macam tu. Red cell with apa? With straight edges. Terbelah. You nampak? Okay, so that's why it's not a straightforward bleeding case. For Maha. Maha is a picture. It's a picture and it reflects this process. Okay, that's how it is hemolyzing internally. Okay, alright. So what happens here? Okay, this widespread thrombosis, you use up all your factors lah, kan? In order to get that clot. You want to get that clot, but here it happens widespread, uncontrollable. That is consumption. Consume sampai tak cukup. Bila tak cukup, you tend to okay. Kita pernah bagi dah soalan ni. Okay, usually you crash and burn every time we ask about the IC. Okay, but I think the last time we bagi tu, I think the whole batch spot benda ni tak. Kali dua Jangan you all markas 10 semua dapat 2,
Ush.
3. Hey. When we ask about pathogenesis or pathophysiology, markah dia memang
10.
okay. Alright. Okay, so investigating DIC, as a doctor, you try to investigate the cause. Okay, this will come with clinical history, examination, other modalities, radiographic evidence or whatever. Okay, history of apa, mak rempit, ibu kereta. Okay, so you know, okay, there is a cause there. Okay, right, and then the other investigations would essentially be looking at the different components. So hopefully when you see it this way, okay, it's a more dimensional rather than having it like straight down, just hafal sahaja. It's more pictorial like this. So you know what has to do, why you are doing it, right? So if you are looking for MAHA, you know why MAHA occurs, so you know you have to do a morphology exam of the blood. Okay, PBS, kita panggil peripheral blood smear ataupun full blood picture. Okay, if there's consumption of your platelets or your coagulation factors, what do you do? Look at this. PT, APT, fibrinogen, platelet count, this will give you numerical numbers. Okay, cukup. How bad is it? Okay, and when you are looking at ischemia, the extent or the effect of the ischemia, what do? You can do LDH levels, you can see metabolic acidosis, okay, and bleeding lah. Ischemia and also bleeding, you will see a reduction in the hemoglobin, right? So when there is widespread thrombosis also, plasmin will come in to apa? Tolong apa? Dia nak tolong pecahkan lah. Kan? Dia nak tolong pecahkan. Okay, so fibrinolysis does come in. Okay, and in this case, you would see that the D-dimer or the FDP or the fibrin split products will be about high or low in this case. Will be high lah. Logic kan? Logic. Okay. So go into this. Go into the different causes of DIC. Okay. So the clinical cause, characteristically, patient, if they are not attended to, complication is shock. Okay. The patients go into shock. Go back into shock. What we mean by shock in this case. Right. So the complication is also bleeding and thrombotic complications. Okay. Alright. So this is a summary. Bolehlah baca. Okay, so I put in also some slides on clotters, okay, or the bleeding of clotting disorders, or what we mean by the clotting. Okay, but you have to admit that this looks a lot like your lecture on thrombosis. Okay. So in terms of the clotter or clotting in hemosis, this generally means the ones that are hypercoagulable. Okay, hypercoagulable, look at it. Okay, they are hypercoagulable. So what we want you to know basically for clotters is who are those who are at risk, higher risk of clotting. Okay, developing this thrombosis. Okay, so when we investigate, it is very specific to the disease. This is already postgraduate stuff. Okay, so kita tak begitu. Okay, and the consequence of having of being a clotter is developing thrombosis wherever there be. But so you are already dah faham about DVT, pernah dengar DVT kan? Dah belajar kan? DVT, okay, you get tissue infarction, or the thrombose go and berjalan, dia jadi apa? Embolism, right? In some instances, because of the clot in the placenta, it causes recurrent miscarriage. Okay? Okay, so homework for hemostasis is a a lot. We will do this when we do your practical, and there are a lot in practical to consolidate what you do. Okay, all right.